This program is brought to you by Emory University.
Good morning and welcome to Cardiovascular Grand Rounds. Today's speaker is Dan Sorescu. Dan grew up in Romania, went to medical school there, and then did his residency at Beth Israel, New York. Then came to Emory, where he trained in cardiology and came onto our faculty. Dan is board certified in advanced heart failure and transplantation and does a wonderful job with our heart failure program at Emory University Hospital, Midtown. On weekends, you can often find Dan on one of Atlanta's great assets, and that's the Chattahoochee River. He enjoys trout fishing, and ask him to show you some pictures sometime. Dan's going to talk about therapy for chronic systolic heart failure.
Thank you, Andy. And it's always a great pleasure to be here. Pretty much this is my home for the last 18 years. I thought I'll review the basic therapies that we have learned, improve survival and ejection fraction in chronic heart failure with reduced ejection fraction. And if we were to look and see heart failure as a progressive disease from stage A, which is risk factors for heart failure, stage B, asymptomatic heart failure, whether it's systolic or diastolic, as diagnosed by an imaging study. Stage C is basically B plus symptoms, which is most of our patients. Stage D is advanced refractory heart failure who will require advanced heart failure therapy or inotrope therapy. Really, for each and every stage now over the last 30 years, we have accumulated excellent data that helps us to progress, to not only prevent actually progression through the disease, but also reverse it. And that's a very important message here. As a matter of fact, I would say that probably at least a third of our new onset heart failure patients probably nowadays with the current therapy can reverse back to normal. I'm going to go over the role of neurohormonal activation in development and progression of systolic heart failure. We'll talk about how impacting that progression of neurohormonal activation actually reverses heart failure and improves mortality and symptoms in these patients. And we'll review also some of the negative clinical trials that we have learned in patients with chronic systolic heart failure. And if we really went, probably the best way to approach this, I thought we'll approach in a historical way. Really, heart failure therapy in the 40s and 60s were consisting mostly of diuretic therapy. The main idea was that kidney is the organ keeping an eye on the heart. When the heart is not doing well, kidney will start to retain salt and water. The volume overload that accompanies will cause the symptoms, congestion, but also progression of heart failure. Unfortunately, only diuretic therapy has not been proven to really improve mortality. As a matter of fact, one of the most potent and first diuretics we used to use, mercury chloride, used to cause permanent diabetes insipidus and basically ATN about a third of the patients. So since furosemide did change that, and then we have different diuretics that we use now, but really in the 60s and 80s, studies from Braunwald actually developed the hemodynamic, and his colleagues developed the hemodynamic model. That was a model where here the body not only fights the heart with more volume overload, but also with increased systemic vascular resistance, arterial vasoconstriction, and increased preload. And all this fights and lowers further the cardiac output. To prove the hypothesis, really only in the 80s, the first study, there was double-blind randomized to prove the hypothesis, compare hydralazine and nitrates with, back then, the placebo, which was digoxin and diuretics. And it's very little known that there were actually two clubs back then. There was one, Jay Kahn from University of Minnesota. His idea was that really you need to work both on afterload and preload with hydralazine and nitrates. Nitrates being venodilators, the hydralazine being the arterial vasodilator, and that was opposing actually Dr. Milton Packard back then at Columbia, who said, well, the really most important thing is the arterial vasodilation. As a matter of fact, there's a little known arm of prazosin, 5 milligrams 3 times a day back then that was testing that particular hypothesis. That was actually never published anything but an abstract, because back then we didn't used to publish negative data. And that arm actually was stopped after 6 months because actually those patients had worse mortality. So hydroxyzine 100 milligrams 4 times a day for our house staff, and isosorbide dinitrate 40 milligrams 4 times a day, one versus digoxin and diuretics after 2 years of follow-up. And this pretty much opened the era of evidence-based medicine, not only in heart failure clinical trials, but also is the first ever randomized double-blind, placebo-controlled trial in evidence-based medicine, as a matter of fact. And if you go through this hemodynamic hypothesis, which prove that, if you try to address that we have issues with afterload preload, you can actually improve mortality in heart failure. Really, the single most important development after that is actually the neurohormonal model. Basically, there's a recognition that patients who develop one way or another elevated cardiac filling pressures and heart failure are going to have a consistent, persistent neurohormone activation, which consists not only of norepinephrine, plasma norepinephrine measured here in the 600 range, but also renin-angiotensin activation. And just so you have an idea, this is a paper by Dr. J. Kahn back then in 91. If you look over the levels that the plasma norepinephrine will measure in these patients, in the 400 all the way up to 1200 range, the worse the norepinephrine, the worse mortality. If you were to run a marathon, the plasma norepinephrine level during that time is about 50 to 80. If you're really well trained, it will be less than that. In a pheochromocytoma crisis, it can go up to 100 or 200. This is 600, 800, 1200. So this really brought the idea that those guys are the ones who actually may mediate all this increased afterload preload, all the further cardiomyocyte loss. And sure, 30 years later, we still don't measure those hormones in our daily practice. But there is a way how we actually can know that. And the test that we do every day is actually the B-type natriuretic peptide. As a matter of fact, is a release as a response to elevated cardiac filling pressure. And I would say it's probably release is the main antagonist of the angiotensin system. Is a release actually as a consequence of the body trying to antagonize and balance the increased angiotensin to release in these patients. And if you look at this BMP as a marker of progression heart failure, it perfectly correlates with the neurohormone activation in early versus advanced stages. The higher the BMP, whether it's in hospital, out of the hospital, you have worse mortality. And actually, if you do whatever you do to the patients, whether it comes with acute heart failure or it's chronic heart failure as outpatient, if they get better symptom-wise, then their BMP gets better. So I would urge you, if you ever think about, well, neurohormone activation is just a nice abstract concept, it's really BNP. You can always look and sort out where is your patient going from that perspective. So, and this starts with, one way or another, heart signals to the brain through chemoreceptors, baroreceptors, and that is somehow the output is not adequate. And I don't think it's really, this is a very low cardiac output centric, hypothesis, which is not true. The cardiac output is really low, only in very, very late stages. I think probably the single most important stimulus is actually just elevated cardiac filling pressures, whether it's left or right, whether it's during the exercise or at rest. And that again correlates with the BMP. So if you do that, actually within minutes of that, the seconds to minutes, the CNS will release and will activate the adrenergic system. And it will activate both as a nervous activation, sympathetic direct stimulation of the heart, but also through adrenal gland, more of a chronic release of adrenaline and norepinephrine. And if this stimulus, whatever is the stimulus, persists, then actually the norepinephrine system the sympathetic system will stay activated all along, but then you start to induce the second system of renin-angiotensin, all right? And this will persist throughout the years as long as there is the same stimulus. And late in the disease, you're going to have aldosterone activation. And that doesn't matter what's the etiology of the cardiovascular hemodynamic stress. And we need to remember that throughout the stages of chronic heart failure progression, these three particular neurohormones are very important. So based on that idea, Then the VHeFT-I trial, which is vasodilated heart failure trial, was designed to test the hypothesis: are we dealing only with the vasodilated problem here, or we also have a neurohormonal issue? So they pick Enalapril, which is an ACE inhibitor that has both of those issues, versus the hydrazine nitrates, and then the Dr. demonstrated that clear Enalapril was superior in improving survival. And this was probably the first hint that it's not just vasodilations and after reduction, but it's also clear those mediators that do all that are more important than actually vasoconstriction, which is just one of the side effects in volume retention. And after this started the ACE inhibitor era in therapy in chronic systolic heart failure, the next study was really the SAFE trial, which is basically a captopril after myocardial infarction. This was really designed by Dr. Mark Pfeffer when he was a postdoctoral research fellow in the lab of Dr. Braunwald, and basically created an animal model, the first rat infarct model of heart failure, and he demonstrated Renin-Angiotensin was increased in the tissue. He blocked it with captopril, prevented, improved survival in those rats and mice, and then eventually this moved very quickly to the humans. And after that, we look into more of a chronic asymptomatic heart failure versus symptomatic heart failure. We designed this all comers, not just myocardial infarctions. It's an NIH-based study that showed that actually you can start as early as asymptomatic systolic heart failure, SOLVE trial, and these patients, if you follow them for anywhere between 3 all the way up to 8 years, they all have improvement in survival. So this pushed the concept that you don't have to wait to get symptomatic heart failure, but actually you can start from asymptomatic stages, more like stage B, to prevent progression of heart failure. So the main neurohormones that we know now that are toxic and essential for this heart failure progression, the Renin-Angiotensin II and aldosterone system, and norepinephrine. Well, Renin-Angiotensin, and in particular angiotensin II, it's important to understand that we get it activated in the adult life. It does the same thing that it does in the fetal life. So if you look in the fetal life, angiotensin II is actually essential for the cardiovascular development. That's how we grow the heart. That's how we grow the vessels. As a matter of fact, if we give ACE inhibitors or ARBs in those patients, in mothers with those babies, we know that it's teratogenic, and these are the main side effects. The catch with activation of Renin-Angiotensin system in adult life is that you're going to reprogram. The heart will never be the same, as opposed to a sport athletic kind of heart where you have actually an increase in adult cardiac myocyte phenotype. This will be a conversion of adult cardiac myocyte to a fetal phenotype. That means the contractile proteins, the energy system that is used, everything is completely different and adaptive for fetal life. Fetal life means the heart will use glucose, so it will adapt to low oxygen. So it's actually a very resistant heart to severe, under nutrition systems, But the catch with that is, it's actually a systolic heart failure heart. It's really ejection fraction in a fetus, it's only 30%. It doesn't need much of contractility because the pressure system is about 5 times less. Now, if you switch that adult cardiac myocyte phenotype to a fetal phenotype, you're going to have a more resistant heart, and typical example is hibernating myocardium. When you have oxygen, it will just shut down and won't function well. But you still have the same pressure system of 5 times higher, with the systolic pressure is not 30 millimeters mercury, but actually 100, 120. So that's the problem. That by itself, while it works acutely, chronic is deleterious. The second thing is important is the mechanism is compensatory, because truly if your ejection fraction is lower, if you actually remodel and you dilate your heart, your stroke volume can be maintained with actually lower ejection fraction. So in theory it works well. The third part is that also the fetal heart is more sensitive to actually adrenaline. If you dump the same amount of adrenaline onto a fetal adult cardiac myocyte versus the fetal will actually response will be to undergo cardiac myocyte apoptosis. So you convert short term, you save somebody's life, but long term, after 3, 6 months, years, this is actually a heart on one hand is metabolically less active, and theoretically it doesn't die right away, but at the same time it's more resistant to adrenaline, more sensitive to adrenaline, which causes further cardiac apoptosis, ischemia, fibrosis, and and more sensitive to catecholamines. So it becomes really, and the same changes don't happen just in the heart. It happens also in the kidney. Is probably the underlying reason for the true cardiorenal syndrome. And all this with time will lead to the symptoms and progression of heart failure. The first who tested the hypothesis actually antagonizing the adrenaline in progressive heart failure in a large prospective double-blind randomized study was actually Dr. Milton Packer, who finally had his revenge after a few years, and he was part of designing the first Carvedilol trial in heart failure. I was second-year resident at Beth Israel back then, and I presented this to a journal club, and I was really back then, if we remember, using beta blockers in somebody with heart failure was kind of a no-no. Everybody thought we're going to kill the patients, they're going to feel terrible, they'll become hypotensive, they'll be in the hospital. And to everybody's surprise, Carvedilol, starting with 3.1 to 5, eventually advanced very gentle to 25 twice a day, really dramatically improved survival and improved the ejection fraction, averaged by about 7 to 8%. But what's really striking is that this separation of survival curves started to happen as early as 3 months. This just has never occurred. And because of such a dramatic effect, very few believed the study. As a matter of fact, was heavily criticized because these were more of a compilation of 3 different studies together, almost like if you win ongoing meta-analysis. So this is where, but it really, just take-home message here is that by far the most dramatic survival response and improvement in ejection fraction as early as 3 months was seen with the beta blocker. Eventually, all this was confirmed in large randomized protective studies showing that 3 beta blockers now clear improved mortality within the similar kind of impact, about 30 to 35% relative risk reduction. Carvedilol, the CBS trials, which concerned bisoprolol, and metoprolol succinate, long-acting, not short-acting, in Mary heart failure trial. They also noticed, most of these studies, they also had a dose-response arm where they show clear that if you compare Carvedilol's 6.25 with 25, there's a dose-dependent improvement in response. As a matter of fact, 6.25 gave about 50% of the mortality benefit as opposed to 25. And we have similar data with lysinoprolinase inhibitors, ATLAS study, which was also designed by Dr. Packer, 10 milligrams versus 40, there's a dose-dependent response. So it's not just the type of drug is important, but also the dose that makes causes the maximum benefit. And this is across the spectrum, whether it's class 1 heart failure or class 4 heart failure. So this is extremely important. And the 3 beta blockers now approved in US for heart failure, it's Carvedilol, bisoprolol, and long-acting metoprolol. In Europe, there is another one called nebivolol, which is almost like Carvedilol, really. Has similar kind of alpha, beta-1, and beta-2 blockade, but it also has a nitric oxide kind of beneficial effect. So imagine you combine nitrates with Carvedilol in one drug, that will be nebivolol. And that's a senior study that was published. That nebivolol is approved here as an antihypertensive agent, but not as for heart failure. But every once in a while, when patients intolerant to all these 3, I actually try to use it. And that's how I see it. But one slide that I want to make a point here, Bristol-Myers, right before Carvedilol became generic, designed a study where they compare metoprolol 50 milligrams twice a day with Carvedilol 25 twice a day. And I guess they were trying to keep the patent going, and bottom line is, back then metoprolol short-acting was generic, so they were trying to win over that. And indeed, it won. I mean, within 2 years up to 5 years, you see clear improvement in mortality with Carvedilol. So metoprolol short-acting 50 twice a day really wasn't doing the job. And there were a lot of speculation why. You have metoprolol XL, which is the same drug, it's just slow release as opposed to short-acting. But the way I see it is this, imagine they use a short-acting agent, for example, metoprolol short-acting 53 times a day, as opposed to metoprolol XL 200 once a day, or metoprolol XL 100 once a day. If, let's say, you have a plasma therapeutic level, okay, the dose of a drug will give you the peak response, which you see, really, the 50 short-acting metoprolol is similar as a peak with metoprolol XL long-acting. But what's different is that area above the curve where you have constant blockade of the receptor at the myocyte level is going to be very different for short-acting really versus, you see these big gaps of unopposed, adrenergic stimulation of cardiac myocytes. And I think that's the main idea. And of course, and bisoprolol is actually similar like metoprolol XL. Bisoprolol again was testing in the CBIS trials, CBIS 1, 2, and 3. And I personally, between metoprolol XL, short, long-acting versus bisoprolol, they're both beta-1 selective. I favor bisoprolol for the simple reason it has a longer half-life, and I think that was the main reason why metoprolol XL was winning over metoprolol short-acting. So if I were to choose, okay, which one do you choose? Do we really know between Carvedilol and the other two beta-1 selective ones? We have some data from actually a retrospective meta-analysis that our own, actually now fellow, Supriya Shore has performed, where they look retrospective all the patients been in this beta blocker, and it seemed to be a survival benefit on beta-1 selective antagonists like bisoprolol or metoprolol XL for the ischemic cardiomyopathies. And one of the reasons could be because you have constant blockade. They have fewer arrhythmias. For example, somebody comes with SVT or AFib. I prefer those agents because you have less a risk of having better coverage for over 24 hours. They're also less hypotensive. So particularly diabetics who otherwise hypertensive do fantastic with Carvedilol because of the alpha blockade. But if you have diabetic and autonomic insufficiency, I had patients who passed out from just the lowest possible dose of 3.1 to 5 of Carvedilol, just like they would do with tamsulosin and other agents. So in those particular patients, if they have autonomic insufficiency, if I document orthostatic hypotension, I like to switch them back to either bisoprolol or long-acting metoprolol XL. And there are also some clinical trials of beta blocker. They were designed, they were negative. And that's important to know too. If you look at various agents that we have there with different selectivity for beta-1 and beta-2 versus alpha-1 versus sympatholysis, I'd like for you to I like to bring the attention to clonidine and moxonidine. And really, imagine clonidine is a central alpha agonist that causes central sympatholysis. It's excellent for blood pressure. Well, moxonidine is just like that, but it only really works only central, does not have the peripheral alpha blocking activities of clonidine, and is long acting once a day. So the idea was Dr. Kahn, who otherwise never designed a negative clinical trial in heart failure, thought, why don't we just block the adrenaline all the way from the brain? We should just wipe out any problem with heart failure progression, at least from adrenaline standpoint. And they designed that study with moxonidine. The study actually was called MoxCon trial in chronic heart failure. And this study, believe it or not, was published only 5 years later in European Heart Journal. And this was probably the trial with the most negative effect on patients with chronic systolic heart failure. While the ejection fraction did improve by 7%, the norepinephrine levels reduced by 50%, they had to eventually stop the trial because of worse mortality. Now, that was back then in the, there were no defibrillators back then, so probably the most, because patients really literally started to drop dead within 30 days of enrollment, probably one of the reasons was that while you stop the adrenaline from the central part, was below having 7 different levels of activation, you get actual upregulation in the system, and that still hits the cardiac myocyte. So I suspect that basically you have a tight control system that unless you block it all the way to the cardiac myocyte system, level, you're not going to improve for real survival. And this might be different somebody with a defibrillator that may protect them, but it can cause probably more arrhythmic death. And my take-home message is this: while moxonidine is not approved in U.S. for heart failure, it's only approved for hypertension. Clonidine is definitely not a favored agent. We probably should avoid clonidine in patients with chronic systolic heart failure. And then one more before I move away from beta blockers. There are a couple of trials. One is called CARMEN, which is Carvedilol based, and the other one is CBIS-3, which is bisoprolol based. So every once in a while, we have patients who are have their relative hypotension, so their systolic pressures of 100, and they just had the myocardial infarction, maybe other different reasons why they could be with their blood pressure on the low side. So if you were to pick an agent, a beta blocker or an ACE inhibitor, which one would you start with first? And this is exactly what these two trials have have addressed. And basically, whether you start with, if you compare ACE inhibitor versus a beta blocker like Carvedilol or bisoprolol, really, it turns out that if you start with the beta blocker, you're more likely you're going to be able, as outpatient, to add an ACE inhibitor, but also they'll be less hypotensive, and it will improve their LV remodeling as opposed to starting with an ACE inhibitor. So, although historically the first agent that we tested in systolic heart failure was an ACE inhibitor, and everybody kind of starts say, well, you have less than 40, let's start with an ACE inhibitor. Really, if the blood pressure is borderline, actually we have stronger data. We should do the other way around with the beta blocker. This is, if I were to pick one agent, this is by far the single most potent and most important to improve the systolic heart failure survival and ejection fraction. So, take-home message is that only beta blockers which have been shown to improve survival in heart failure should be used. At the dose, try to make every effort to really use it at the dose that has been clinically tested in prospective randomized studies. So if I were to look across heart failure progression, anywhere from New Heart Association 1, stage A, risk factors for heart failure, if you go all the way to class 4, stage C to D heart failure, as a matter of fact, beta blockers, ACE inhibitors have been proven to be effective. I'm going to now switch gears, and I'm going to talk about the next neurohormonal system. Remember that it comes the last in the neurohormonal activation progression of heart failure, and that's the aldosterone. And if you look at the aldosterone, we have basic science data showing that whether it's animal, whether it's cells, or whether it's humans, that pretty much anything we know is bad in cardiovascular disease can be reproduced by aldosterone. And probably in regards to heart failure, the single most important will be clear they're involved in ventricular arrhythmias, ventricular tachycardia particularly, and it's part of baroreceptor desensitization reflex that occurs with patients with progressive chronic systolic heart failure. And this baroreceptor desensitization is very important because you don't have a way of turning off persistent activation of your adrenaline. So if baroreceptors, that's the way how the brain sends it, that you need more adrenaline. If baroreceptors are not activated, then the brain thinks you don't have enough adrenaline, and will keep going that. And it's very, very important. And indeed, if you look at clinical trials with aldosterone receptor antagonist in heart failure, we had two studies that were designed. First, the RAIL study, which are more of a class 3 to 4 heart failure patients that already are on beta blockers and ACE inhibitors. And Dr. Cohn is the one who Dr. Bertram Pitt back at the University of Michigan is the one who designed the study. And it showed clear that not only beta blocker and ACE inhibitor, but also spironolactone in those patients with advanced heart failure will improve mortality. And it will improve mortality not just by improving survival, also risk of sudden cardiac death. Now, the genius part of this spironolactone actually was, before he designed the study, he met with pharmacologists. And the low dose, it turns out spironolactone at low dose versus high dose, the one we use in systolic heart failure, 25 twice a day, has a completely different effect than if you were to use the diuretic dose, which is at 100 milligrams twice a day, is used in patients with ascites and cirrhosis. So this very low dose effect is less hyperkalemic, but also works by really preventing actually not only arrhythmias, but also cardiac fibrosis. So aldosterone is a trophic factor for cardiac fibroblasts in the heart, the same way angiotensin is a trophic factor for cardiac myocytes. And that pathological ongoing cardiac fibrosis is the one that is in charge of what we the line between reversible and irreversible heart failure, and also the line between the risk of arrhythmias, particularly ventricular tachycardias. So here, this slide shows that both trials, the FACC trial, which was post-MI acute heart failure, left ventricular ejection fraction less than 35%, versus progressive heart failure class 3 to 4, it showed clear survival benefit, improvement in risk of cardiac sudden death. And then for a while, for about 7-8 years, we had this, was good for class 1, was good for class 3 to 4. Nobody knew exactly, but what happens between class 2 to 3. And then a couple of years ago at the AHA, the Emphasis HF trial, which was a chronic outpatient class 2 to 3 heart failure, they randomized Eplerenone versus placebo, which was beta blocker ACE inhibitors or ARBs if they are ACE inhibitor intolerance, really they show that even in that middle group, you have predominant, you have improvement in survival in these patients with heart failure, with minimal risk of actually for hyperkalemia as long as they are washed careful. So now, if you were to have somebody who has an ejection fraction less than 35%, they should be on beta blockers across the spectrum, an ACE inhibitor across the spectrum, and aldosterone receptor antagonist. Of course, with careful follow-up, and you got to pay attention with those who have a creatinine higher than 2.5. In those patients who are actually ACE inhibitor intolerant, then we have several clinical trials that look into the role of angiotensin receptor antagonist. This is just showing. This was part of the aldosterone, trial showing the really only patients who actually they're treated with spironolactone and eplerenone. Only those who actually dropped their plasma collagen marker were the one who improved actually survival, proving that the reason why we use these agents is actually to prevent ongoing cardiac fibrosis, not necessarily as a diuretic effect. Okay, so now if we go back and we try to sum this up, okay, so far, what have we learned for 30 years of clinical trials in heart failure? Well, we learned that if you block the renin-angiotensin system and you block the adrenergic system, you have dramatic improvement in survival. And there's one more element, and that's the element both of this system at the cellular level actually cause an imbalance in activation of oxidative stress. And we have the last system that we really made progress is actually showing that if you reduce that oxidative stress, you can improve survival in heart failure too. And let me get back to that. That might be like a novel mechanism for you, but that is the true mechanism that we have here. If you look back at the vasodilator heart failure trials, the hydrazine nitrates, I think we got it right, probably for the wrong reason. It is true that hydralazine is an arterial vasodilator and will improve after load in those patients. It's true that nitrates do that too. But really at the cellular level, if you were to look, they noticed that in certain patients, particularly African Americans, the heart failure is slightly different. If you really remove those African Americans, they were very underrepresented in the VHeFT trial, first of all. Second, they noticed the African Americans had more benefit from hydrazine nitrates as opposed to ACE inhibitors in Caucasians. And they have a tendency to have lower incidence of coronary disease, they're more hypertensive, they have lower level of plasma angiotensin activation. If you look at the cellular and molecular mechanisms, really, particularly African Americans, if you look at the cardiac myocyte or a smooth muscle cell, endothelial cell, the really vasoconstriction or vasodilation is purely regulated by a balance between nitric oxide and superoxide. And nitric oxide is released by the endothelial nitric oxide synthase, while the superoxide is released by an 8-BH oxidase. And really, we owe to Kathy Grilling, who was and is still my mentor, and I got in the lab a few years after she published first time in 1994 that there is an NADH oxidase making superoxide in smooth muscle cells. And then eventually, together with Dave Lambert in the lab, they cloned actually, and they identified this now known as NOx enzyme. And this is very important in subiubiquitous. Every cell type has it. And Dave Harrison, back then actually having a fellow in the lab, Thomas Munsell, proved that actually the main mechanism how hydralazine actually causes direct arterial vasodilation is actually through blocking this enzyme. So if you block this, in patients with progressive heart failure, there's clear an imbalance between nitric oxide and superoxide. If you block with hydralazine 8-BH oxidase, you're going to shift that balance to the left. And if you give nitrates from the pocket, you're going to shift it back there. And if you look in African American endothelial cells that were isolated from umbilical veins of healthy African American women. And you look at their nitric oxide versus superoxide production. Here in Caucasian ones, you see how there is a relative balance between nitric oxide is way more produced in these endothelial cells than superoxide. But if you look in African Americans, the relationship is exactly opposite. So for whatever reason, there's a genetic predisposition in African Americans. The endothelial cells make more superoxide and less nitric oxide. Superoxide, ideally you want to have a balance. If you have more superoxide, you have more vasoconstriction, you have more cytotoxic effect on long term. So based on all that data has accumulated, including with VHeFT trial results, they designed Dr. Kohn and his colleagues designing again the final trial called the AHEF trial, where patients who were already on beta blockers, ACE inhibitors, and aldosterone receptor antagonists, self-identified African Americans with a dilated hypertensive, more of a heart, diabetics. They were randomized to hydralazine, a total of 225 daily, and isosorbide dinitrate total of 120 daily, as 2 pills 3 times a day of what's called now Bideal. And they showed that clear, if you follow these patients up to 2 years, you have improvement survival. Now, I want to point out here that really the survival curves, they start to separate after about a year. So the benefit is not right away, as opposed to beta blockers, which are within 3 months. You have to get, and there are a lot of pills there. If really it's only on top of the others, and it starts for at least a year. So this is not necessarily my first choice to start these patients on. I will start them with the other ones, the beta blockers, inhibitors, and aldosterone receptor antagonists, and then I will add this if the patient is compliant and is willing to and has access to all these pills. So now I'm adding the last line here of hydralazine nitrates, and I wanted to go back to the idea of how about the patients who are ACE inhibitor intolerant, and we have excellent clinical trials with aldosterone with angiotensin receptor antagonist in these patients. We have a valsartan-based study, we have losartan, 3 allied trials, and we have candesartan study. And by far, probably the most beneficial in these patients, including improving survival, is actually the candesartan. Okay, if I were to pick one ARB that at least in the clinical trial show clear improvement survival, not just in rehospitalization, then the perfect ARB would be candesartan, which is more of a long-acting tissue penetration, once-a-day kind of agent, as opposed to valsartan, which is intermediate, and losartan is actually the worst from that perspective. As a matter of fact, after the initial enthusiasm with the LIGHT-1 trial with losartan 50 twice a day, when they went back and they did that just for heart failure, really a LIGHT-2 trial didn't show any benefit, and I think the catch was they only used 50 once a day, has poor oral bioavailability. Eventually, years later, we designed the LIGHT-3 trial, which was 50 milligrams 3 times a day, and that has similar potency, as a matter of fact, as candesartan. The problem with that is that, of course, when you push up the dose, you get more frequent, you get more side effects. So there's a little higher risk of renal failure and hyperkalemia if you are pushing it at 53 times a day. And how many of you have used candesartan? Well, there's a catch. It's an excellent ARB. It's probably the best ARB, and telmisartan is known to be similar, and some other these long-acting. The catch is it still costs over $200, $300 a month, and basically our patients, because of insurance purposes, don't have access to it. You can prescribe, even with the insurance, it's top tier. Patients, everybody recommends losartan. So even if it's amazing otherwise, I can't use it. I use losartan 50 twice a day. The data is not even there for improvement mortality. And if I were to use 53 times a day, which we have data for the dose, Medicare, Medicaid, and the insurance companies don't approve you use it. So either way, you're kind of stuck here. If you have an ARB, you really don't have, and a patient is ACE inhibitor intolerant, you really don't have good choices for that. Until when? Until now. So about a year ago, the Paradigm HF trial came out, where compare angiotensin, a fused drug. It's called Paradigm because actually they came up, it's not 2 different substances in the same pill. It's actually a fused drug from an angiotensin receptor antagonist like valsartan and a neprilysin inhibitor, and I will talk about, which compare that with Enalapril. And the main idea was this, that if you look at the balance between vasoconstrictors and vasodilators in patients with heart failure, really, we know that the balance favors the vasoconstrictors. But this balance is tilted to the left because of the actual vasodilators. A lot of them are inactivated. So when we look at our patients progressing heart failure, we measure the BNP, even if it goes to 1,000, 2,000, 3,000 as an attempt to compensate for vasoconstriction, most of it is actually inactive, it's neutralized. And it's neutralized when one of the enzymes being this neprilysin, it's a neutral endopeptidase. And they came up with the idea, why don't we try to shift this balance back by actually inhibiting this neutral endopeptidase. And believe it or not, this Entresto is not really a new drug. The first drug was tested as an inhibitor for neutral endopeptidase was omeprilate in heart failure. And there's a trial called OVERT-HF trial that was published many years ago and only got published to Circulation and not in New England Journal because unfortunately they had to stop the study. They actually use omeprilate. They say, let's completely block everything that relates with, let's increase the vasodilators, but also use an ACE inhibitor. So when they use both agents compared to an ACE inhibitor, patients develop a lot of angioedema, and they had to stop it. So that didn't work out well. And when they figured that out, they said, hold on a second, why is that? Why is there a problem? So here's why it's a problem, okay? If you look here over this side, the ACE enzyme is the one that sure activates angiotensin 2, but also inactivates bradykinin, right? So if you use an ACE inhibitor, then you have more bradykinin in the system. Bradykinin is the mediator of sepsis, anaphylaxis, and if vasodilation, leaky capillaries, anything you want. You really don't want that to have too much of that. Now, if you look at the other way of inactivating actually bradykinin is actually by neutral endopeptidase. So either you inactivate with ACE, angiotensin converting enzymes, or with neprilysin. So we figured that with using omeprilate and an ACE inhibitor, you can't really go too far because while you may benefit from heart failure perspective, you're dying from angioedema or horrible dry cough as a side effects. So they say, well, let me do this. Let's leave one side of this bradykinin to work. And they chose to actually block the angiotensin by using valsartan, which works straight on receptor, combining that, fusing it to a neprilysin inhibitor called sacubitril. Initially, they labeled it LCZ696. Now is trademarked as Entresto. So when they did that and they compared that with Enalapril 10 milligrams twice a day, which was the classic dose in SOLVE trial, actually you have a tremendous benefit, probably the 20% improvement overall cardiovascular mortality, and 16% of all mortality in these patients with chronic heart failure already on beta blockers and ACE inhibitor. And obviously this is amazing, but there is a catch. So the catch number one is if you look at the survival curves, when they really start to separate, it really takes at least a year, if not, 2 to 3. As a matter of fact, on an analysis they showed that the patients who are supposed to survive beyond 5 years are the one who would benefit the most. So it will sound like a great agent early in the disease, but you won't get a benefit for at least a year in terms of survival, as opposed to ACE inhibitor. So second part is you still have, if the patient is ACE inhibitor intolerant, you can't really use it. You're still going to get the same angioedema or dry cough they used to get with ACE inhibitor. So you can't really use it as an ARB, unfortunately. It's the same problem. And last but not least, see how potent is the benefit when you look at large-scale population. We assess that by using necessary number to treat and NTs. For example, if you were to use a biventricular pacemaker, you need to treat 220 patients to save one life. And that's, again, just the effect of CRT. I'm not talking about the defibrillator part, okay? That's a lot. That's extremely expensive if you want to do it at large scale and only for certain few patients who have the left bundle. If you were to look at necessary number to treat for Carvedilol, for example, is 22, and it's used to be $4 at Walmart, so way cheaper. If you were to look for aldosterone receptor antagonists, just a little more. And Paradigm HF trials show that with Entresto, it's 35 to 1. You need to treat 35 patients to improve mortality. ACE inhibitor would be like 40, for example. But imagine that from these 35 patients, 80% of benefit is actually given by $4 ACE inhibitor. Okay, and the rest of 20 is from $4. You go all the way up to $300 a month, and that's based on what actually the actual data is now. It's anywhere between $300 to $400. So of course the companies came out saying, we just got to balance the risk benefit also and the ability of the patient to follow up. Also, if we can afford this at large population, of course, the company says that, we give you these coupons, you're covered for the first year, but each and every patient have one Entresto. After that year is gone, then insurance automatically goes up and you pay full price, which is $300 to $400 a month. And so they don't benefit, when actually the benefit is supposed to start from there if they tolerate. Another catch with that is that it is a much more potent vasodilator and antihypertensive agent than actually ACE inhibitor itself. So you really, patients who were enrolled in the trial, they're actually excluded if systolic blood pressure was less than 110, which a lot of our patients. So this is not for borderline, low blood pressure patient that is a first agent. This is for patients who ideally they are probably hypertensive. Ideally they don't have any side effects from an ACE inhibitor, and that's why the current guidelines don't use it necessarily, although it's a more of a class 1B indication. The guidelines encourage you to start with an ACE inhibitor. You repeat the echo in 3 or 6 months. If the EF has not improved, patient is not doing well, you have room for blood pressure, and they can afford it, go ahead and use Entresto. For those patients who say, I don't care how much it costs, I want the best for myself and blood pressure is good, I offer it to them, but I explain to them, you got to really do a good analysis and be honest with the patient with all this. So, and that's where we are with that. Now, last but not least is my least favorite agent, which is not everybody shares my opinion with this, but I still think that in the evidence-based medicine era, you have to remember that the digoxin trial, which was designed came out in 2000, really showed a perfect overlap in survival between digoxin and the placebo line. So really, we don't have survival data with digoxin. It's been said that improves hospital readmission, and probably the most beneficial effect that we know of digoxin, it seems to have a great role in resensitizing those baroreceptors, which are important to turn off the adrenal system. However, if you look at the analysis based on the digoxin level in these patients, really the patients who may benefit from it, sinus rhythm, good kidney function. If you have a digoxin level below 0.8, probably it's safe, you can use it. If you have this level as 1 or higher, you actually have worse mortality. So the true digoxin toxic level is, for fellows here, is not really 2 like when you're doing power chart and you see the lab. It's actually 1 or higher if the patient has anything suggesting sign or symptoms of this toxicity, which is the most frequent is actually VT and ICD shocks. And I promise you, each and every year, I have at least 1 or 2 patients that I have to take them off digoxin because it's poorly recognized as causing their VT or they have this toxicity. Most likely to get this toxicity are females and patients who have labile renal dysfunction, particularly patients with advanced heart failure. So it's a complicated situation because who do we put on digoxin? Those who are more advanced heart failure, they don't tolerate our ACE inhibitor and beta blockers, and yet they're more likely to get also the dish toxicity. So be very careful about that, and remember, there is no survival benefit. I don't care how you turn it around. There are a lot of little extra studies. They show all kinds of little potential benefits. Patients feel worse if you stop it. I don't know about that. I can tell you I've never had any problem with any patient I took off digoxin. They do just fine with the rest. But that's now I have questions. Patients ask me sometimes, how about vitamins and supplements in heart failure? What can you do? Well, one of them, they might be there to stay. We don't have the most outstanding data, but recently, at least in the last 7-8 years, there are a couple of studies that show that patients with chronic systolic heart failure, whether it's ischemic or non-ischemic, there's a GC trial for ischemics, and there's a non-ischemic smaller study by Georgiade. They show that actually 1,000 milligrams of omega-3 supplementation may improve ejection fraction on top of beta blocker, ACE inhibitor, and everything. So those patients want, hey, it's not going to hurt, may cost a little bit. The idea, we want to get to 1,000 a day minimal, and I encourage them to do that. I don't think we have fully proven this hypothesis, but we have data from both ischemic and non-ischemic, and again, low ejection fraction. So I label it as promising future ahead, and particularly those patients really want to, they have asked the nutrition question. Really, the others, I'm not going to review here for lack of time, but the TNF-alpha receptor antagonists have been proven to be negative. Endothelin receptor antagonist, negative trial. Most recently, remember the last neurohormonal system activates in heart failure is really the inappropriate secretion of anti-diuretic hormone. And if you can antagonize at only the V2 receptors at the kidney level by using tolvaptan or canivaptan. And the Everest trial, which was an outpatient trial, the largest trial to actually test the hypothesis, was negative. It did improve the sodium. It helped them to diurese a little more, but it was negative overall as a survival. There's also an acute version now that has been, I think, recently published used as a direct purposes with a price that's about $270 a pill, which is a day. All right, as a diuretic, that was -2. They did improve that, but it didn't improve any rehospitalization or mortality. So I would not use it as a chronic outpatient. I would use it very rare as an inpatient or a patient that otherwise drops the sodium below 125. They already failed the fluid restriction, and you absolutely really have no other way. You still need to diurese. They have no other way of improving that sodium, and they are symptomatic. Go ahead and use it for 2 or 3 days, but I wouldn't use it more than that. And remember, it will be at $300 a pill a day, at least the way it's right now. So having said that, I really thought it sounds like a boring topic to review what we all have known for the last 30 years. But we are at the point where we seem to have very little, improvement in what we do with mortality and rehospitalization patient with heart failure. But we forget one thing, that if I have a problem with going further, maybe it's because I forgot what really works. And guess what? We know this works. If you look at a patient who is only on that JACC and diuretic, their survival by at 1 year is about 15%. So their mortality at 1 year is 15%. So 1 out of 6 will drop dead, I tell them, or about 50% by 5 years. If you add a ACE inhibitor, that drops by about 25%. If you add an ACE inhibitor and beta blocker, and I would say spironolactone, then you have about 60% benefit of that. And really, if you add the defibrillators or pacemakers on top of that, you can get that all the way down to 5.8% a year. So, and having those excellent, therapeutic options, it is underwhelming when you actually look across the spectrum. If a patient has a certain ejection fraction, less than 35%, then really, whether you look in Europe or you look here, less than 40% of patients are actually on these 3 medicines: beta blockers, ACE inhibitors, and spironolactone. As a matter of fact, again, it's not just being on these 3, but also the dose is important. So you do that, and I think the best to improve what we're doing is actually to try to push it and really get that much better than we're doing right now. Because basically we don't have half of the benefit. It's gone just from that. And meanwhile, we're arguing about 20% rehospitalization by 30 days, and we don't pay attention to really works. I think we need to, particularly for the house staff and the fellows, we need to pay attention, and we got to work diligently in getting them tolerating this medicine and work on it. So if for our fellows, if patient is in the hospital, drop the ejection fraction for whatever reason, what medicines, what type of beta blocker or ACE inhibitor you're going to use. As I mentioned, any of the beta blocker, that would be the first and the must if they tolerate. I have a preference for Carvedilol if it's a non-ischemic cardiomyopathy, hypertensive, because you need more room for blood pressure. If they're diabetic with neuropathy, they're very orthostatic, they won't tolerate it. I promise you that. I will switch to, in they are ischemic with a lot of VT or AFib and ICD shocks. We prefer the long-acting beta-1 selective antagonists like metoprolol XL or bisoprolol. I work hard for bisoprolol to be on formula for 2 years. All right. In exchange, I gave up Neseritide, which was we didn't lose anything there. But this is very important, as house staff needs to get used with those agents. As a matter of fact, bisoprolol is still cheaper as outpatient metoprolol XL, although it's not, like Carvedilol. Any ACE inhibitor, it doesn't matter, this is a cross spectrum. Anybody with class 2 or higher heart failure. And all you need to do is to secure that the patient will follow up and you have a follow-up CAM7 in a week, basically checking a potassium. If the blood pressure is borderline, start with the beta blocker. That's the data we have. You don't start with an ACE inhibitor, more likely to be hypotensive and less likely to be able to add the other agent. And remember, just because you have a creatinine 1.6, that's not really a contraindication for aldosterone receptor antagonist, because there's tremendous benefit in survival and the risk of sudden cardiac death. It's a great chemical chemical ICD. So you do need to follow them more closely. You gotta know that the hypokalemic effect takes about 2 weeks. It doesn't happen from one day to another. So you have to, the key is to make secure that patient will follow up with it. I wouldn't use it in the first choice if I don't know the patient, but if they come up, they're compliant, that's where I'm going to add my aldosterone receptor antagonist. And the exclusion criteria in the trial was creatinine less than 2.5, not less than 2. So as long as you have a compliant patient, they're fine. In summary, I wanted to I went over the basic strategies and drug therapies that showed to improve survival. Beta blockers, the 3 that I named, ACE inhibitors. If patients ACE intolerant angiotensin receptor blockers. Most recent paradigm trial showed that agent like LCZ 696, it's excellent in those patients who have not improved on ACE inhibitor, particularly the ejection fraction. They still have room for their blood pressure, and they can afford it. Aldosterone receptor antagonists probably should be right next to beta blocker and ACE inhibitor as a potency. Hydrazine and long-acting nitrates are for those patients who are self-identify as an African Americans on top of the other agents, not instead of the other agents. And really, the digoxin, so far, the only proven outcome is to maybe improve, reduce hospitalizations and improve symptoms in only those patients who actually have less risk of digoxin toxicity. Again, not patients with renal failure or arrhythmias. Thank you. So I'll be happy to take any questions.
Great, Dan. We always learn something from Dan. We have a number of excellent clinicians at Emory, and one texted me during your talk that he noticed that I was a little bit dyspneic when I did the introduction. I did run up the stairs when I got here to be on time. I know that if I were to check my norepinephrine level, hopefully it's not above 400, but maybe in that 40 or 50 range, and my BNP level wouldn't be elevated. Before we get to questions, I want to remind everybody that tomorrow at noon for internal medicine grand rounds, our cardiology fellows will be presenting on cardiogenic shock, Dr. Badia, Dr. Krim, Dr. Corrigan. So be there in the auditorium here or watch from the satellite presentation. Your comments around the neprilysin inhibitors, Entresto, it really has not been studied in patients who have been real sick in the hospital. And within our heart failure network, we're about to start a trial in the next 2 weeks that will look at that. So many of you who are on service may be approached about possibly having patients randomized to that therapy to look at this in sicker patients. Let me open it up for questions. Steve. Here you go.
Dan, thank you. When you start adding on Bidil, seems to me Bidil turns out to be an expensive medication. It gets to be a lot of pills for a person to take. When you start talking about following up a potassium in a week, that gets to be tough when your patient is from far away. And when you talk about endpoints, survival as an endpoint, is that the right endpoint? So those are my points that you can comment on.
Really, the three agents show not just survival, but also improving symptoms and hospitalization. So, it's important for the patient not to come to the hospital and actually feel better. So it's not just that. Now, digoxin might be a little different. You're right, quality of life is important, particularly, and we need to address those also for particular population in the rural area. But most of them, actually, the way we sort that out, I let them continue with their primary cardiologist and the primary care, and we establish a relationship, and we make sure they understand they can check that locally, and then they fax us the results also, they can follow there. So it requires lots more. You're right, it's a serious concern and a legitimate reason here, but it requires us more connectivity and more communication. But that's an important point. Also, a very good point is that at the end of the day, for a lot of our patients, quality of life becomes, particularly older, more important than the quantity. And sure, we need to focus on that. That is kind of difficult to address by itself because, as you know, our clinical trials for acute heart failure have not really shown much of an improvement. And but things that matter are like congestion, which is what makes them come in the hospital. That we can address as outpatient with diuretics, but that's a completely different topic. I agree. Yes, go ahead.
Dan, thank you for an excellent talk. I learned a lot. I'm gonna take Dr. Clement's question to the next level. So for HeFrEF, we have such high mortality, so it's very reasonable to pick mortality as an endpoint. And I know we have given excellent talks on HeFrEF in the past. So my question is, if you were to pick an endpoint for a HeFrEF clinical trial, what would be that?
I think whether we like it or not, we have to pick all the standard endpoints. I mean, symptoms are important for the patients, so you have to have some way of showing that you improve that, and you have to look into the mortality part too. I am aware that in HeFrEF is very, we have limited data, really no benefit in terms of improving it, maybe because of 50% of those patients actually died of a concomitant comorbid illness and not from heart failure per se, so you have so much less room to improve there. My concern with the clinical trials designed for HeFrEF is that they were actually not designed the same way we designed for the one for the HeFrEF. I think we're having a major ideological problem here, because in HeFrEF, in HeFrEF, we added one at a time the agents. So we started with a vasodilator, then a diuretic, then we added the vasodilator, then we added the beta block, then we added the ACE inhibitor, and we added spironolactone, and we kept them when we saw that. I think that I don't see why we don't design a trial for HeFrEF where you use all three of them, and that has not been done yet, which is wrong. Beta blockers, ACE inhibitor, or ARB, and spironolactone, combine them all three, plus minus diuretic, and then have the other ones placebo, whatever they want to do. And I think that's where we're missing the boat here if you want to improve that and give the best back for your money. And I think how you do it, that's one. And then second, I still think that we're going to have to look at all the mortality, survival, but also improvement in patient symptoms, which are probably more important than hospitalization. So,
Dan, we have a question. Somebody asked, what in titrating doses and that sort of thing, what dose of spironolactone should we aim for?
So really what has been used in the RAIL study, it's a dose of 25 or 25 twice a day for those who are bigger weight, like over 100 kilograms. So I wouldn't go any higher than 25 twice a day. Maybe the planon dose was started with 25 twice a day and goes up to 50 twice a day. If you go on spironolactone higher than that dose, which sometimes we do, particularly the potassium low, they require a lot of furosemide, feel free to do that. Know that it's going to have a diuretic effect and you can run into issues with hyperkalemia. But really, 25 once a day or 25 twice a day spironolactone is suffice for this purpose. And it is hyperkalemia, it is a dose-dependent effect. So at 12.5 reportedly, you don't have much of a side effect with that, but 25 twice a day, you can expect that. Again, it won't be within a few days. You need to look in a week or 2 weeks later, and that's what makes the difference.
Great. Thank you so much for an excellent presentation. Hopefully we'll see everybody at Grand Rounds tomorrow at noon.
The preceding program is copyrighted by Emory University.